Because we all know that in androgenic alopecia, the main problem is miniaturization of the hair follicle. So the hair follicles become increasingly smaller and thinner, and they produce hairs which are smaller, thinner, and hypopigmented. But at one point, there is a follicular dropout. And we have to keep this in mind if we have a patient who comes to our office with a long-lasting androgenic alopecia. Sometimes in trichoscopy it may even appear as cicatricial alopecia because we do not see any hair anymore, any hair follicle openings, and this may be a moment where the treatment will not be effective. So when we want to introduce treatment, it is the earlier we start, the better, and if we should not be surprised if we see features similar to androgenic cicatricial alopecia in this patient. The main feature of androgenic alopecia is hair shaft thickness heterogeneity, as in this image, and this is the image of the man whom you have seen in the previous image. And here, a very late onset or a very late androgenic alopecia, which may make the impression of a cicatricial alopecia. Maybe you can also see some white dots. So we may think that this is lichen planopilaris or a later version of a lichen planopilaris, so we should not be surprised with this image. What is characteristic about miniaturization in androgenic alopecia? I mentioned this already. This is the fact that this is non-synchronized. So there will be one hair which is already going the way of miniaturization, another hair is still in a good condition, and the other hair will be at the very end of this process. So we will have, at the end of the spectrum, vellus hairs. The vellus hairs are the very short, very thin, and hypopigmented hairs, nearly invisible. When looking into numbers, these are hairs which are less than 3 millimeters in length, less than 30 micrometers in thickness, and they have no pigment. So when you look from far, this will be appearing like total alopecia. And because this is not synchronized, we will see in one field of view hairs which are thick, thinner, and very thin. And this is, you have seen this image already today, this is unlike miniaturization in other diseases where the miniaturization is diffuse and it goes in a similar way throughout the scalp. Just as a differential diagnosis of androgenic alopecia, the synchronized hair thinning will be present in several systemic diseases, in malnutrition, in deficiencies, and also in cutaneous cell lymphoma, and androgenic in many diseases which are induced by endocrine diseases. So this is not unusual to have hair thinning. But in androgenic alopecia, this is the only disease where we will have non-synchronized hair thinning, and this will appear as hair shaft thickness heterogeneity in trichoscopy. So this is the number one and most important feature of trichoscopy of androgenic alopecia, is the presence of hair shaft thickness heterogeneity, meaning that there in one field of view you'll see hairs which are very thin and hairs which are very thin and thick, and usually more than 10% of vellus hairs. Vellus hairs is number two, a very typical feature. You may find some vellus hairs in a normal, healthy person, but if it starts being more than 10%, then we have to think about androgenic alopecia. As mentioned already before today, if you're using a dermoscope with immersion fluid, you may not see you will not see the vellus hairs. So it needs to be dry trichoscopy to have the vellus hairs visible, because otherwise with immersion fluid they become invisible. So these are the vellus hairs, and the dry trichoscopy and trichoscopy with immersion fluid. And just as an example,